So the topic is psoriasis treatment and cancer, new perspective. And I will introduce you the story of Roberto. Roberto is a 62 years old man with diffuse psoriasis and psoriatic spondylitis, as you can see in the picture on your right, that has been treated with infliximab for 3 years with good disease control, either on the skin and joint symptoms. However, Hodgkin lymphoma stage 3B was diagnosed while Roberto was on biological therapy. And so, what would you do in these circumstances? So Roberto is on infliximab, TNF inhibitors, and develop biological therapy. Interrupt the therapy, continue the therapy, or discuss with the hematology whether to interrupt or continue the therapy with TNF inhibitors according to the clinical condition of the patient. What happened? The therapy with infliximab was interrupted. I stopped the treatment. We can discuss after if you agree with me with these choices. Patient was referred to the hematologist. Hodgkin lymphoma was treated with chemotherapy and radiotherapy. And fortunately, psoriasis was cleared during this chemotherapy and radiotherapy period. So I asked to myself, is there is any risk of Hodgkin lymphoma in patients with psoriasis? Yes, no, maybe, has never been investigated. We performed a systematic review and meta-analysis investigating this outcome, with the objective. Why? Because it has been reported an increased risk of lymphohematological malignancies in patients with rheumatoid arthritis, IBD, for instance, and systemic lupus erythematosus, Sjögren's syndrome, and dermatomyositis. It is likely that in a genetic predisposed background, immune signaling dysregulation, inflammatory environment, as long discussed earlier, could lead to a chronic activation of B and T cells that contribute to the pathogenesis of lymphoproliferative disorder. So we did these systematic reviews. We selected more than 1,300 manuscripts. We screened, and a total of 25 observational studies were selected, including collectively more than 2,500,000 subjects. And we found that a significant increased risk for lymphohematological malignancy, any lymphoma, Hodgkin lymphoma, non-Hodgkin lymphoma, and multiple myeloma and leukemia was found in psoriatic patients compared to control. And among lymphohematological malignancy, cutaneous T-cell lymphoma has been more related, more associated with psoriasis. And again, this could be related to the exposure of systemic immunosuppressive therapy, comorbidities, and the effect of sustained immune activation, particularly on the skin. Then we asked to ourselves, is there any risk of cancer in patients with psoriasis on biological therapy? And also this topic has been already discussed by Lone, but very briefly, in this study, an increased risk of non-melanoma skin cancer, particularly squamous cell carcinoma, was reported with TNF inhibitors. but no risk regarding other type of cancer, including lymphoma, melanoma, prostate, colorectal, and breast cancer. And also this study has been mentioned. Fortunately, in these large studies, data on treatment with biological agent did not show an increased risk of cancer. And in this study from Verona, from the epidemiological department, seem to suggest no differences exist between treatment of chronic cutaneous disease with TNF inhibitors, ustekinumab, apremilast, tofacitinib, and conventional DMARDs in terms of melanoma, while data on non-melanoma skin cancer are more controversial. So in this study, it was a comparison between biologics and conventional systemic treatment. So coming back to Roberto. After a period of 3 years of remission, recurrence of diffuse psoriasis was observed, as you can see in the picture. PASI 22, BSA 70%, physician global assessment 5, and also back pain complaint. Then Roberto developed also diabetes, likely related to the corticosteroid therapy, arterial hypertension. So he was receiving also metformin and ACE inhibitor. So now, which treatment for psoriasis would you recommend now for Roberto? Topical therapy? I think that topical therapy is not enough in the case of Roberto. Acitretin could be good for the skin, but not for the spondylitis. I'm not expecting an efficacy of acitretin on spondylitis. Cyclosporin, I think you will agree with me that it's not the case to prescribe cyclosporin for Roberto, either for the comorbidities, either for the history of previous lymphoma. So no cyclosporin. Methotrexate, why not methotrexate? Although it's not so effective on the spondylitis compartment, but for the skin. Biologics, apremilast, fumaric acid esters, others. Phototherapy was not feasible at this time because Roberto was on the mountain close to Verona, so not easy to come to the hospital 3 times a week for phototherapy. What I did? Firstly, what guidelines are recommending? This is all for the Euroderm guidelines. Guidelines recommend, taking the burden of psoriasis into recommendation, and it should be a shared therapeutic decision, taking into account also what the cancer specialty suggests us. So for a patient with recent malignancy, recommend topical therapy, phototherapy, and or acitretin. In case of inadequate response to topical therapy, phototherapy, narrowband UVB, and or acitretin, guidelines suggest using methotrexate in patients with psoriasis and previous history of cancer. And they suggest apremilast can be used in psoriasis patient with a previous history of cancer, despite the long-term experience, based on pathophysiological consideration and case-by-case basis, including discussion with the cancer specialist against. Suggest against cyclosporin, as we discussed before, in patients with psoriasis with a previous history of cancer. And then suggest anti-TNF, ustekinumab, based on existing safety data on case-by-case basis, and also suggest IL-17 and IL-23 inhibitors can be used in patients with psoriasis and a previous history of cancer, despite the lack of long-term experience, but based on pathophysiological consideration and case-by-case basis, including discussion with the cancer specialist. We have a small experience, this is in 12 patients, with IL-17 inhibitors. This is case series with different type of malignancy, resolved malignancy, when methotrexate was not enough, was not effective, azacitidine was not effective, and phototherapy was not feasible. So we have an experience with IL-17, different type of IL-17 inhibitors, and a follow-up ranging from 6 to 48 months with no recurrence of disease progression. Then even for Italy also, we have participated to these multi-center studies, observational study with different 42 patients with different type of cancer, from melanoma to breast cancer, kidney cancer, prostate cancer, and all treated with secukinumab, so again IL-17 inhibitors. Most cases were in early stages, only 4.8% at distant metastases. The secukinumab was effective with a mean PASI reduction 90%. No tumor recurrence, no progression occurred over a mean of 56 weeks. 3 patients developed a new malignancy, but not related to the previous cancer. So coming to the case of Roberto, firstly, I give to Roberto methotrexate, 15 milligram weekly plus folic acid administration, but the response was not good, was poor, not satisfactory response. So IL-17 inhibitor was combined, has been combined, achieving almost complete sclera control with satisfying back pain control. I think that you are convinced that the response of the skin is very good. And fortunately, the psoriasis still is in remission with no recurrence of lymphoma. So in summary, in the setting of patient with malignancy and history of malignancy, selecting the appropriate treatment for psoriasis could be challenging, because patients with malignancy are excluded from clinical trials. In this setting, collaboration with cancer specialists is very important. Multidisciplinary approach is a value, and a limited number of treatment could be preferred in case of recent malignancy. But we should consider that there is a relatively small number of patients treated with biologica, with heterogeneity of cancer type and short duration of observation. So in conclusion, my feeling, my perspective is that any coin has two faces. In the picture on your right, you can see a sestertium, the ancient Roman coin. It was a present from my father. From another phase is the risk of relapse. The other phase is the need to treat the patient. So in the case of patient with history of malignancy, I think that is wise to know how to balance the risk of recurrence with the opportunity to offer to the fragile patient the treatment for severe psoriasis she needs. Firstly, I prefer phototherapy, methotrexate, and apremilast, but if a patient requires biologic, I prefer IL-17 or IL-23 inhibitors. Thank you very much for your attention.